Hello, my name's Kristoffer Russell. I'm an interventional cardiologist at Oslo University Hospital in Oslo, Norway. So today I want to talk about prosthesis patient mismatch and particularly in younger patients. So patient prosthesis or prosthesis patient mismatch can occur where the effective orifice area of the valve that we are implanting is physiologically too small in relation to the body size of the patient, and therefore does not meet the cardiac output needs of the patient. So this effectively leaves the patient with a residual stenosis or outflow obstruction, even in the presence of a normally functioning bioprosthetic valve. From the surgical literature surrounding surgical aortic bioprosthesis, we know that if the mismatch is severe, or even moderate in some series, the patients are at greater risk of mortality, heart failure hospitalization, decreased valve durability, and reduced functional recovery. So the Valve Academic Research Consortium 3, VARC3, labels PPM as non-structural valve dysfunction, and using the patient's body surface area as a surrogate for cardiac output, defines PPM based on body surface area of the patient relative to nominal effective orifice area of the specific valve. So for non-obese patients, a moderate PPM is defined below 0.85 square centimeters per square meter, and severe PPM below 0.65 square centimeters per square meters, and the cutoff is slightly lower for patients with a BMI over 30. Furthermore, from the literature, it seems that PPM is less likely to occur after TAVI compared to SAVR. However, insights from the TAVI registry from Herman et al. Showed moderate or severe PPM to be present in up to 30% of patients after TAVI. As some of the consequences of PPM may take years to manifest into clinical endpoints, there is limited data connecting PPM to negative clinical endpoints in the TAVI patient base. However, there is growing evidence that, like for surgical bioprosthesis, PPM may have a negative impact on patient outcome. So earlier this year, Suruga et al. Published the as yet largest study with longest follow-up to examine the clinical impact of predicted PPM in younger patients with low risk. So these patients were around 70 years old with an STS score of 1.5. So in this single center retrospective observational study, which included patients with severe aortic stenosis who underwent TAVI with newer generation balloon expandable valves, they found that measured moderate or severe PPM was present in 39 of the 512 patients investigated. Furthermore, they found that the presence of PPM was associated with higher all-cause and cardiovascular mortality, increased heart failure hospitalization, and less quality of life improvement over the 5-year follow-up period. So the authors conclude that PPM was frequently observed in young, low-risk patients following TAVI with newer generation balloon expandable valves. This was especially prevalent in association with younger age, female sex, where pulse dilatation of the THV was not performed in patients with small annuli and patients with larger body surface area. And indeed, it seems that in this study, high BMI might be an important driver of PPM and unwanted outcomes. However, these findings further support the importance of placing effort into minimizing PPM during TAVI to improve long-term outcomes in this patient population. For TAVI, PPM can be measured using echo velocities after implantation, or it can be predicted. From the manufacturers, effective orifice area for the different platforms are available. And there is even a nice app for this. So from this, and knowing the body surface area of the patient, we can calculate the theoretical risk of PPM. However, it is important to keep in mind that to achieve the nominal effective orifice area, we also need to achieve optimal expansion of the THV. Unlike for SAVR, where the predicted effective orifice area of the surgical valve is fixed, the final size of the THV prosthesis is determined by the native annular size and may also be hindered by other factors that may impede nominal valve expansion, such as heavy calcification, unfracturable surgical bioprosthesis, or bicuspid anatomy. So this might also explain some of the observed differences in predicted versus measured PPM seen in several studies. So in the continued quest to optimize patient outcomes through refinement in implantation techniques and rigorous pre-planning, I believe that assessment for potential PPM should be part of this pre-planning. Putting the anatomical measurements together with patient size and implanting a valve with adequate effective orifice area makes sense. And this may be even more important now as we are treating younger patients with more active lifestyle and a longer life expectancy. So regardless of valve platform, optimal valve expansion seems to be important for long-term outcomes. There are, of course, many anatomical considerations when confirming the appropriateness of the valve choice. In some patients at risk of PPM, however, PPM may be avoided by using a self-expanding supraannular valve. Because of the supraannular leaflet insertion, a larger effective orifice area may be achieved in the equivalent native anatomy as compared to intraannular valves. Furthermore, the same design may potentially be less vulnerable to underexpansion, making it possible to achieve nominal effective orifice area and hence avoiding PPM. So like for surgical bioprosthetic valves, current findings support the importance of placing effort into minimizing PPM during TAVI to improve long-term outcomes, in particularly in patients with longer life expectancy. However, there is still a need for further research to improve prediction and assessment of the risk of PPM and how best to avoid PPM in patients undergoing TAVI.